talk about some of the pearls of using duloxetine. So, duloxetine's biggest niche is in pain treatment. So, Cymbalta is FDA approved for diabetic peripheral neuropathy, fibromyalgia, and chronic musculoskeletal pain. And it's used off-label for other neuropathic or chronic pain disorders. So, doses greater than 60 milligrams have not shown to have clear benefits for pain, but it's not uncommon to go to higher doses. Now, duloxetine has a few endorsements from a few medical associations. So here they're getting a nod from professional organizations outside of psychiatry that include duloxetine in their guidelines for management of pain. So duloxetine is recommended as first line for chemotherapy-induced neuropathy by the American Society of Clinical Oncology. It has a grade B for diabetic neuropathy by the American Association of Neurology, and it's listed as conditionally recommended for osteoarthritis treatment by the American College of Rheumatology and Arthritis Foundation. And the last painful indication that I haven't mentioned yet is that duloxetine is often used to treat painful physical symptoms in depressed patients. Now, I will say, when you read up about this stuff, it can be very confusing because you can see very mixed things. In some papers, you'll see it confidently stated that the medication doesn't work. And then in other papers, you'll see it clearly stated that it's effective. So how I make sense of this is that duloxetine is not a silver bullet for any of these conditions. It certainly doesn't cure the condition, and it definitely shouldn't be pitched to patients as if they're going to be all better. What we typically see is that in pain scales, it tends to reduce the pain by a point or two. So I would imagine that for patients who think that the medication is going to cure their pain, the medication would be very disappointing. But for patients who understand the limitations of the medications, I would imagine that it would be greatly appreciated. All right, now let's talk a little bit more about the specifics for each condition. So in a Cochrane review for the use of duloxetine for painful neuropathy, chronic pain, or fibromyalgia, these are the conclusions. There is adequate amounts of moderate evidence that doses of 60 to 120 milligrams are efficacious for treating diabetic peripheral neuropathy, but lower daily doses are not. In fibromyalgia, duloxetine is effective at similar doses, so 60 to 120 milligrams, and with a similar magnitude of effect. The effect for fibromyalgia might be achieved from greater improvement in mental symptoms than in the pain. For pain associated with depression symptoms, there is low to moderate evidence. So the number needed to treat for an additional beneficial outcome is 8 in fibromyalgia and depression. So I feel like this Cochrane review captures what I was saying earlier, where we see low to moderate evidence and efficacy. Now, the other condition is general chronic musculoskeletal pain, and here we see similar results as to other conditions. So duloxetine isn't typically considered first line in treatment recommendations, and it's considered conditionally recommended for hand, knee, and hip osteoarthritis. So this level of recommendation is just a step below strongly recommended. And here it's typically said that it should be started at 30 milligrams and then increased to a max of 60 milligrams. Now, just since we're talking about pain, I'll also discuss a little bit about migraines. So the SNRIs are definitely not considered first line for migraine treatment, but duloxetine does have some studies that show varying degrees of efficacy. So the way I would try to capture it is I think SNRIs can be considered for a patient with migraines and comorbid depression or anxiety, where you're going for a two birds, one stone approach. But the SNRIs probably aren't considered a reasonable choice if migraines are the only thing that you're trying to treat. All right, let's talk a little bit about duloxetine and fibromyalgia specifically. So, fibromyalgia is a condition defined by chronic widespread pain, and it's accompanied with fatigue, sleep, memory, and mood issues. The gist is that the brain lights up with pain more than it should. Now, SNRIs are commonly used here because they tackle the pain and then some of the other common symptoms of the disorder. So, duloxetine is one of the most used medications. Worldwide, it's milnacipran, which is an SNRI not approved for major depression in the US. But let's take a second and look at the Cochrane review. So the major conclusions from the Cochrane review looking at SSRIs and SNRIs are that there is clinically relevant benefit in pain reduction of 30% or greater, and for patients' global impression to be much or very much improved. But they found that there was no clinically relevant benefit for pain reduction of 50% or greater, health-related quality of life, reducing fatigue, or reducing sleep problems. So their conclusion was that on average, the potential benefits of duloxetine and milnacipran outweigh the potential harms in fibromyalgia. And note that a minority of people with fibromyalgia might experience substantial symptom relief without clinically relevant adverse effects. So the Cochrane review fits what I mentioned earlier, that the average patient could expect mild or maybe moderate relief. Now, the last Cochrane review for pain that I'll go over is in regards to a network meta-analysis for antidepressants and pain management. Here, they state that the only antidepressant that they're certain about for treatment of chronic pain is duloxetine. And they note that duloxetine was moderately efficacious across all outcomes at a standard dose. And they also mention that there's promising evidence for milnacipran. Now, I think looking at duloxetine in depression will help us wrap up how to view duloxetine overall. So, in a Cochrane review of duloxetine versus other antidepressant agents, the author concluded that duloxetine did not provide a significant advantage in efficacy over other antidepressants for acute treatment of depression. They note that there were no differences in terms of efficacy, and that duloxetine was worse than some of the SSRIs, most notably escitalopram and the other SNRI venlafaxine in terms of acceptability and tolerability. Now, I don't want you to think that that means that duloxetine isn't effective in depression, because it is. So, for the differences of the medications that had better efficacy or tolerability, the differences are very modest. So, the important takeaway here is that if you're trying to treat just depression or anxiety, then duloxetine should not be used first line. And that the heuristic that increasing 2 neurotransmitters is better than 1 just doesn't generalize here. So, to summarize all these different pearls, duloxetine is effective in pain, but it's not a magic bullet. And duloxetine is effective in depression, but it's not superior to other antidepressants. Where duloxetine can shine is in the 2 birds, 1 stone approach, where a patient needs treatment for depression and for pain. So you have the opportunity to use one medication to have them treat both conditions. Pain relief, you prescribe, enhancing neural pathways to revive. Ooh, block that net, increase norepinephrine, dig in duloxetine.